Joining me for this Tell Me More About session is Alberto Monje from Spain. Alberto, welcome.
Thank you so much.
You are one of the speakers in this amazing Monaco Congress, and you're talking about the AAP, the American Academy for Periodontology, and the EAO, the Academy of Osseointegration, new guidelines for the prevention and treatment of peri-implantitis. It's one of the key plenary sessions in Plenary 3 tomorrow. Welcome.
Thank you.
We're about to dive in deep. Let's first start with the basics. Why is it important to talk about these new guidelines here in this Congress?
Indeed, when we try to translate all the scientific knowledge into the clinical basis, it's highly important, to provide guidelines for the prevention and for the treatment of peri-implantitis. So it's not only a matter of gathering all the scientific evidence that have been collected over the last decades in the prevention and management of this entity, but also to feed ourselves from the clinical perspectives that many expertise have around the world in understanding better the pathogenesis, aspects related to the prevention and management, put them all together in order to build up these guidelines.
Yeah. Now, the field of peri-implantitis is still a lot of developments going on. Mm-hmm. Let's start with the incidence rate. What are the developments there?
Well, the fact that nowadays the incidence and the prevalence, as explored in observational and cross-sectional studies respectively, has slightly varied, it's actually attributable to the changes in the case definition. In the year 2017, it was held a workshop in peri-implant diseases and conditions. And in point of fact, at the time being, it was shown that at the patient level, the prevalence of peri-implantitis were about 43%. Nowadays, it seems that the most updated systematic review that was actually part of this American Academy of Periodontology Joint Academy of Osseointegration consensus meeting seems to be slightly lower. And as I
define slightly, are we talking 10% points or?
It's about 10% lower, but it's not actually the fact that we are preventing disease in a more effective manner, but the fact that now the threshold in order to consider peri-implantitis has a slightly increased, so we have some sort of gray zone in between that previously were defined as peri-implantitis, and nowadays we conceive them as mucositis.
Exactly. So we're not exactly sure that we're really defeating this disease, but that's an important takeaway. So the numbers are going down, could be a matter of definition. Tell me a little bit more about these guidelines. To what extent or in what areas are they focusing on?
Specifically, the American Academy of Periodontology guidelines focused on two primary objectives. First of all, which are the elements that are somehow involved in the prevention of peri-implantitis, and how we can deal with the disease by treating it by non-surgical and surgical means. So in terms of preventive measures, we have explored some novel elements that were perhaps underreported in the literature, such as surgical and implant-related factors. And that's pivotal because, when analyzed the epidemiology of peri-implantitis, no matter what type of a study and where are the studies carried out, there are always a common path, which is that it's an implant-specific disease. What does it mean? That the prevalence at the patient level tends to be about 2 times higher when compared to the prevalence at implant level. I'm going to make it easier for you to understand. That means that if you are carrying 3 dental implants and only 1 implant has been diagnosed previously with peri-implantitis, you are a peri-implantitis patient, so you are a deceased individual, but only 30% of your implants have peri-implantitis.
Okay, that's a smart remark. And again, in interpreting the data, you say what is novel is that we now have guidance specifically on the surgical side and the implant side. Can you elaborate a little bit on that?
We're certainly gaining insight, and that's why these guidelines are also so important, because they motivate, they encourage other researchers to move into that path in order to understand better what is the role of, in this case, these local confounders, these local predisposing factors, that if we are able somehow to address them prior or during the surgical phase, we are going to be more efficiently preventing peri-implantitis.
Yeah. Is there something that sticks out? Is there anything you can mean? Like if a surgeon is watching right now, what is the one thing where you're like, okay.
There are a few of them, in fact. We have shown in the latest consensus, the one that I participated in Oak Brooks, which is a village very close to Chicago 1 year ago, was that, for instance, implant malposition, something that was disregarded until now, it's pivotal. If an operator,
the development of peri-implantitis in the later phase.
Right. And if you try to find out what is the main contributor for that is the operator. So if the operator is undertrained or has not received the most effective education in order to know how to approach the surgical phase or the prosthetic phase, it's a matter of time to have disease.
Wow.
Yeah.
That is a novelty. Any other things that stuck out for you?
Yeah. So in what regards to for instance, the implant-related factors, now that we are talking about these local confounders, we have found that there are some clinical tendencies. And, in light of that, the Spanish Society of Periodontology very recently actually adopted all these measures, and we have another consensus meeting and work using the Delphi method. So we were trying to anticipate in some areas that were gray zones where the Europeans and the Americans both agreed that there is no sufficient body of evidence in order to provide some suggestions. And it's interesting, Gary, the fact that 70% of us, we were like 40 participants, so 70% of us agreed that there are some clinical tendencies in order to prevent peri-implantitis, even though there is not or very limited scientific evidence to support those aspects. And we also agreed in that consensus meeting that implant, surgical, and prosthetic-related factors are actually pivotal to be controlled prior to placing dental implants. So in a way, the operators that place the dental implants have to envision where the prosthetic suprastructure are going to fit in order to condition the soft tissues, to accommodate the environment, to provide the most effective dental implants that few of them have shown to be superior to prevent peri-implantitis, especially when using some transmucosal components, the components that are joining the restorative area to the intravony area, the area that is inside of the bone.
Exactly. And if I listen to you carefully, I think the key new message here is then that peri-implantitis is not just a disease that can overcome a patient. You actually could have quite some responsibility as the treatment planner.
Yeah, if you want to flip the coin, I will say that peri-implantitis is somehow preventable.
You would go that far already in 2025?
In 90% of the cases that we see on our daily basis, it is, unfortunately for us.
Yeah. Well, but it also sounds, if you do your job carefully and well, according to the science that's available, you should be able to prevent in 90% of the cases, right?
There are two major areas that define the prevention of peri-implantitis. The first one is the host. You have to accept that an implant carrier should be a good candidate with a low risk profile. And then, of course, you have to be sufficiently trained in order to conduct the surgical phase and the prosthetic phase in an effective manner, following biomechanical and biological principles that they should be assembled in order to provide long-term success, long-term effectiveness.
Since you are so deep in all this data, is there any data already how much of the peri-implantitis cases can be assigned to poor case selection versus not following treatment planning carefully? Yeah, what is the division?
Our group actually recently, in the official journal of the European Academy of Osseointegration, the COIR, just released some interesting data that pinpoint six local factors that are somehow responsible, we can say, in the onset and progression of peri-implantitis. And all of them are actually local confounders. We do know that there are some systemic drivers, and both the Europeans and the Americans agreed that smokers, patients with hyperglycemia, patients that do not undergo supportive periotherapy are going to be significantly more exposed to the disease. But then once we have overcome the limitations inherent to the patients, then it's a matter of us to conduct implant therapy, again, in a responsible way, we can say.
Yeah, but then, so my curiosity is about, do we know in how much of these cases it's actually poor case selection? Like we know these risk factors, but I'm wondering, do you have any data on whether professionals just step those boundaries or whether they are respected?
It's difficult to measure, but a few cohorts have actually suggested. One of them, one of the highest reports recently, well, not recently, but I mean over the last decade, published on the prevalence of peri-implantitis, the study by Jan Dirks, suggested that indeed the operator is significantly influencing the outcomes down the road, the level of education. So it's difficult to measure because there are multiple variables, of course, but I do believe that that's the message, that peri-implantitis can be preventable and that we should be sufficiently well educated in order to understand whether we are prepared to move into implant therapy and whether the patient is going to be responding favorably to the long-term successful outcomes.
Exactly. Now, Alberto, I can imagine in a place like this where we are now, in a congress where people are talking about protocols, scientific guidelines and everything else, this all sounds almost logical, right? Oh yeah, follow the steps, follow the science. However, in the real world, we still see a lot of prevalence of peri-implantitis. What do you say is the biggest challenge for clinicians out there that drives them away of just sticking to the handbook?
I will say that this is still education. I do believe that participants that attend to this Congress are, of course, so eager to learn and to embrace all the knowledge that is being provided along these three days. Regrettably, this represents less than 1% of our implant community. So the other 99%, our endeavor as educators is actually try to make it easier for them. And I do believe that that's another rationale for providing these guidelines, trying to synthesize and trying to provide like reasonable guidelines in order for them to stick on them and to prevent this type of disease.
Exactly, and make this knowledge more spreadable also for people who might be a little bit less involved in science.
Approachable for everyone.
Exactly, approachable is a nice word.
Yeah.
Now, you talk about these new guidelines, which refers to old guidelines or current guidelines. There's also already a European guideline. Can you comment anything on the difference or the next steps that these American guidelines add to the existing knowledge?
One of the major benefits actually that had the Americans were that we nourished from the European Federation of Periodontology guidelines because we didn't mean to be repetitive, and at the same time we wanted to accommodate and to adopt few of the knowledge and messages that were actually provided in there. But we both agreed that in light of the sparse information in certain topics, especially in what regards to the treatment of peri-implantitis, much is yet to be explored in order to certainly provide more solid, more conclusive guidelines, hopefully in the near future. Exactly. So this is evolving.
Would you say that these current guidelines are all more focused on the prevention or any news on the treatment options as well?
They are both. The truth is that over the last decade, we have learned so much about prevention. So that's why...
That's why the conversation starts with prevention.
Right. And that's also why I'm so convinced that peri-implantitis is preventable.
Yet.
Because everything suggests that local confounders actually are the major responsible for disease occurrence. But when it comes to the treatment, there are so many variables that actually dictate the treatment modalities. Not only that, also the industry is so much interested about dealing with peri-implantitis. So we might get so misled about few instruments, agents, tools, whatever available out there in the market in order to deal with peri-implantitis. This is the reason why we, as researchers, have to explore a few elements that have biological plausibility in order to provide something straightforward, like a recipe that can be, again, approached by anyone in order to deal with peri-implantitis.
But do we hear you say we're not there yet?
We're not there yet.
The industry might be overselling in their marketing messages or overpromising, let's put it like that.
Overpromising because they have not been yet scientifically validated. So we have to be cautious yet. Yeah. Even though I do believe that few elements are highly promising to decontaminate the implant surface, which I believe that that's a major challenge now in the management of peri-implantitis, but we are not there yet. So we have to be cautious in providing robust conclusions in order to minimize any likelihood for in the future regret providing these guidelines.
Exactly. Fantastic. So you say the main driver to actually perhaps prevent peri-implantitis altogether in the future is education.
Education, yeah.
As a final question, how can people watching this, we're obviously preaching to the choir, because people who are not only attending Congress, but also dive into Monaco online and watch these Tell Me More About all the way to the end in this part, they like to be educated. What is the key argument or thing we can tell them or give them to bring in their peers and friends and colleagues to also educate themselves?
Well, the appealing part for them to become educated, because nowadays, Gary, education, if you want to become educated, you can get education from any media, from any source. But the most attractive part for them is to find out that if complications occur down the road on their cases, their profits are going to decrease. So I do believe that that's a great motivation in case that you are facing implant dentistry just as a profitable way for facing life.
I think it's smart to bring in the economics, right?
I do think so. Yeah, of course.
Yeah. So investing in your education now will be a longevity of your practice in your clinic in the long.
Invest on your education, invest on adequate materials that have been scientifically proven, invest on instruments that can warranty or that can enhance the likelihood to be successful in preventing and treating peri-implantitis. And I'm sure, that at the end, they're going to feel so much grateful for that.
Exactly.
Yeah.
Alberto, thank you very much for sharing your knowledge. And thank you for watching this episode all the way to the end. Now, if you're curious and you want to find out more, check out all the other videos here on Monaco Online. Check out the Tell Me More About sessions with the speakers. Or you can even find Alberto's full talk of Plenary 3 as a recording on this platform.